Thank you for the opportunity to give this presentation marking the start of History Month, October, in the Geoffrey Kaye Museum of Anaesthetic History. October is also the month that the Australian and New Zealand College of Anaesthetists celebrate National Anaesthesia Day. Each year we celebrate National Anaesthesia Day across Australia and New Zealand on the 16th of October, which is the anniversary of the day in 1846 that ether anaesthetic was first demonstrated in Boston, Massachusetts, USA. As this day occurs this weekend, this year on a weekend, we are celebrating on the 18th of October. And pertinent to this presentation is that this year's theme is having a baby and obstetric anaesthesia. This presentation that I'm giving today was first given as the Pugh Day lecture in Launceston earlier this year, commemorating Dr. William Russ Pugh, MD, and the administration of the first anaesthetic in Australia. And as I was not able to travel to Launceston this year due to COVID-19 restrictions, that presentation was given by Dr. John Paul, OAM. So I have a couple of disclaimers here. The first is that I'm not an historian, so I'm presenting it from an anaesthetic perspective. And also in this short presentation, I won't be able to mention all the people that have been key in the development of obstetric anaesthesia in Australia. So, an obstetric anaesthetist, what is our current role and what do we do? Well, importantly, we provide anaesthesia for women having caesarean section surgery and also analgesia for childbirth, and that is mainly in the form of epidural analgesia. For caesarean section surgery, we mainly provide spinal anaesthetic, but sometimes we also provide general anaesthesia as well. What you may not know is that we also are key people in deciding whether a person receives a blood transfusion or not, and we're involved in the resuscitation of many critically unwell pregnant women. We play a major role in making sure that a person is also optimised before they have surgery. And this is a field of medicine that is being formally developed and is known as perioperative medicine. Also, in this particular area of obstetric anaesthesia, because of the nature of the work we do, we find ourselves being significantly involved in advocacy for equity for pregnant women, for their involvement in research, and for their access to best clinical practice. But how did we get to where we are today, and what does the future hold? To explore this, I'm going to take you through the years from 1856 to 1901 and the very beginning of obstetric anaesthesia in Australia. The twilight years from 1902 to 1950, the modern era from 1951 to 2019, and then the new world era from last year to today. And I've divided history into these eras as they represent the periods of time during which four major developments in pain relief and anaesthesia for pregnant women occurred in Australia: chloroform, twilight anaesthesia, nitrous oxide, and neuraxial anaesthesia. And what I hope to also do is to show the close link we have had and still have with the United Kingdom regarding our practice of obstetric anaesthesia. I also want to emphasise once again that I've picked out just a few anaesthetists and key people in all these years, and there are so many others who have contributed to what obstetric anaesthesia is today in Australia and New Zealand. In the time before the early 1800s, the only anaesthetic or analgesic agent that was used to help with the pain of childbirth was alcohol. So it was a huge discovery when chloroform was first synthesised in 1831. And the first anaesthetic for childbirth by inhalation was given by the Scottish obstetrician, Dr. James Simpson, in 1847. In his words, "It is our duty as well as our privilege to use all legitimate means to mitigate and remove the physical sufferings of the woman during parturition." This type of anaesthetic was commonly used in the United Kingdom, but how did it come to be used in Australia? To answer that question, we are extremely fortunate to have an amazing publication by Dr. Janet McCall about the first women's hospital in Australia, the Royal Women's Hospital in Melbourne. In her book, Sex and Suffering, Women's Health and a Women's Hospital, Janet McCall, an historian who specialises in historical population health, covers not only the history of the hospital, but also all the societal and healthcare changes since the mid-1800s. It is a fascinating book, and much of the information I present in this talk comes from that book. In the mid-1850s, the colony of Melbourne was a bustling town, and two young obstetricians, Dr. Richard Tracy from Ireland and Dr. John Maud from England, saw the need for a lying-in hospital, a hospital that cared predominantly for unmarried or homeless mothers and sex workers. Working with a ladies' committee, which was very common in that time, led by Mrs. Fanny Perry, they established Australia's first hospital for women, the Melbourne Lying-in Hospital and Infirmary for Diseases of Women and Children. This was later to be known as the Royal Women's Hospital, then simply the Women's, the hospital I work at today. It was in this hospital that Doctors Tracy and Maud used chloroform to provide analgesia and anaesthesia for poorer women who had complications of childbirth. Problems for pregnant women at this time included extreme poverty, malnutrition, infection that was unable to be treated, blood loss and hemorrhage without effective treatments like blood transfusions, and uncontrolled high blood pressure and fitting, a disease and condition we still refer to today as eclampsia, and very, very high death rates, with a death in every 23 women who gave birth. From Janet McCall's book, the hospital environment and the weather was also very challenging for most of the population in Melbourne at that time were immigrants. In 1857, Isabella Weil, an Irish immigrant, wrote, "You say I told you nothing about the climate, but what with dust and heat and hot winds and flies and an insect they call mosquitoes, we do not know what to do with ourselves just now. It makes me quite cold to think of winter, yet for just now, we are all just melted with heat." And for those of us that live in Melbourne, we can still to this day relate to some of those statements, with the 4 seasons in one day, a frequent statement about Melbourne's weather. After the first hospital for women was established in Melbourne, many colonies around Australia followed with building lying-in hospitals, like the ones here you see built in Brisbane and in Launceston. Here are the photos of the lying-in hospital in Melbourne from 1856, the Brisbane Lady Bowen Hospital in 1864, and in 1897, the Launceston Hospital. History in Australia has been kind to anaesthesia, and we have an amazing museum, the Geoffrey Kaye Museum, the creation of which I will talk about later in this talk. Many of the pictures used in this presentation come from this wonderful museum. This museum has won awards and is definitely worth a visit next time you come to Melbourne. Here is a mask that was commonly used to administer chloroform to women with complicated births in Australia in the mid to late 1800s. A metal frame was placed over the patient's nose and mouth, and a triangular cloth mask was placed over the chloroform frame, and chloroform was dripped onto it to relax patients. Despite being effective for pain relief and enabled surgery to occur in a pain-free manner, problems with chloroform began to emerge, with deaths occurring during anaesthesia, and that occurred in about 1 in 3,000 to 1 in 6,000 people. So it started to become less popular in obstetrics. But women still wanted, needed, and in fact demanded pain relief. So the era of the Twilight Sleep began. In 1902, Dr. von Steinbuckle of Austria first used morphine and scopolamine for analgesia in labour. Morphine was also used for pain relief, as it gave very, very strong analgesia, and also scopolamine combined gave amnesia and sedation. And this technique was known as Twilight Sleep. Here are 2 pictures from the Geoffrey Kaye Museum showing portable hypodermic syringes. These ones would have been used in early 1900 in Australia to administer the Twilight Sleep to pregnant women during labour. During this period of time, the Royal Women's Hospital in Melbourne and other lying-in hospitals expanded. This time was, of course, a time when the Spanish flu occurred in 1990, and many of these hospitals were repurposed and their wards were used to accommodate sick and dying people with the Spanish flu. It is very interesting to reflect on this in the light of repurposing of some of our own hospital wards that is happening now, not only in Melbourne and the rest of Australia and New Zealand, but throughout the world with the COVID-19 pandemic. But back in the early 1900s, it was a period that the specialty of anaesthesia and its subspecialty of obstetric anaesthesia began to flourish in Australia. Dr. Geoffrey Kaye was born in Melbourne in 1903, but was educated in England. He obtained an MBBS, MD, and DA from the University of Melbourne. He decided to specialise in the relatively underdeveloped field of anaesthetics. In 1934, Geoffrey Kaye established and was one of the 7 founders of the Australian Society of Anaesthetists. Over time, the ASA was to develop special interest groups, and in combination with the Australian and New Zealand College of Anaesthetists, formed much later in 1992, and the New Zealand Society of Anaesthetists, they developed special interest groups. And this tripartite group was the first to form an obstetric anaesthesia special interest group in Australia and New Zealand, in which Professor Michael Paik, who I will discuss later in this talk, was its first chair. The ASA remains today a peak not-for-profit representative body of Australia, of anaesthetists in Australia. It has over 3,400 members, and as a member-funded organisation is dedicated to supporting, representing and educating anaesthetists to ensure the safest possible anaesthesia for the community. In 1935, the Geoffrey Kaye Museum was established, and this was in the same year that Dr. Tracy Morn, one of the founding obstetricians of the Royal Women's Hospital in Melbourne, died. It was also around this time that pregnant women no longer wanted to be fully anaesthetised for the birth of their babies. They wanted instead to be awake and to be part of the experience. Their wishes were answered when at the Royal Women's Hospital, there was the appointment of the first director of anaesthesia, Dr. Kevin McCall, and a new era of obstetric anaesthesia was born in Australia. This is the era I'm calling the combination era, where women had access to nitrous oxide, also known as laughing gas, epidural analgesia, and injections of morphine and pethidine, and later infusions of drugs like fentanyl for the relief of pain. The so-called combination era began in 1951 with the appointment of Dr. Kevin McCall as the first director of anaesthesia and the first obstetric anaesthesia department in Australia. Dr. Kevin McCall, a doctor trained in Ireland, moved to Australia in 1951, and he can be truly called the first obstetric anaesthetist in Australia. From this department sprung many departments of obstetric anaesthesia around Australia, with dedicated directors, as well as anaesthetists who had leadership roles in obstetric anaesthesia in their hospitals. So back to Dr. Kevin McCall and the first department of obstetric anaesthesia in Australia. Dr. Kevin McCall established standards of practice and techniques at the Royal Women's Hospital that quickly spread throughout Australia and New Zealand. These included the development of antenatal classes, administration of anaesthesia by doctors, not midwives, the use of safe nitrous oxide for pain relief in labour, and importantly, spinal anaesthesia for safe and pain-free surgery. From Janet McKelman's book again. Throughout his long career, he was never to have an anaesthetic death and was to remain a steadfast critic of poor practice in medicine. This picture shows Dr. Kevin McCall on the left explaining the use of nitrous oxide through a mixing device that delivered 70% nitrous oxide and 30% oxygen, a safe combination to breathe. The other pain relieving techniques that were developed during this time as part of the combination of medicines and techniques to reduce the pain of labour and to enable caesarean section to occur were caudal anaesthesia, epidural anaesthesia, spinal anaesthesia, and much later the combined spinal epidural technique. These photographs show the different basic equipment used to perform these techniques. The term neuraxial is often used to describe all of these techniques because they anaesthetise nerves along the axis of the body as part of the nervous system. During this time, the role of data collection and auditing of anaesthesia practice became very important, and anaesthesia safety improved considerably. And with this, we started to see a significant reduction in maternal deaths. The longest running and most successful medical audit in history is the report on confidential inquiries into maternal deaths, covering maternal deaths in England and Wales from the years 1952 to the present day. On the left are the details of the first audit, and on the right is the cover of last year's report. Australia also followed on from the United Kingdom and now produces regular maternal mortality reports. Fortunately, our maternal mortality rate is amongst the lowest in the world, with only 1 death in every 20,000 births. One of the components of a medical system that contributes to decreased maternal death and better outcomes for women during childbirth is the ability of a hospital and a healthcare system to support research. Obstetric anaesthesia was promoted by Professor Michael Kaye, one of the first professors of obstetric anaesthesia in Australia. Michael Kaye, having just retired, was based at King Edward Memorial Hospital in Perth. He was inspired by Dr. Peter Brownridge in Adelaide, who was using low-dose epidural techniques and epidural pethidine for analgesia in pregnant women for over a decade before it was used in mainstream practice. From his early inspiration, Mike pioneered the use of low-dose patient-controlled epidural analgesia, also known as the walking epidural, where patients would be able to give themselves a dose of analgesia through an epidural when they felt they need it. From as early as 1990, King Edward Memorial Hospital was using very low doses of anaesthetics and morphine-like medications in their epidurals so that it could be used for pain relief, but it did not make the women have very heavy or exhausted legs, so they could therefore walk around during labour. This was very significant. The so-called heavy epidurals that made women's legs very heavy during childbirth was very common at that time, and to have this new technique where you could walk during anaesthesia and analgesia was amazing for many women. Michael Kaye promoted the use of the combined spinal and epidural technique, the kit of which is shown here in this picture. This technique increased maternal satisfaction with birth and improved pain relief. So we have come a very long way in controlling pain and improving safety for pregnant women. These are some of the pictures from the Royal Women's Hospital in Melbourne today, taken this year. This is our birthing suite room, and no longer multiple beds in one long room like in the 1800s. This is our operating theatre, equipped with modern anaesthetic machines, rapid fluid infusers for the treatment of women with obstetric hemorrhage, and ramping pillows for women who are significantly overweight to lie on during their caesarean section surgery. The problem of excessive weight was something that did not exist in 1856 when the hospital was founded, but has become commonplace today. And now, of course, there is a new era, one that we are immediately in, and in which there lies, probably like at the start of any new era, a significant degree of uncertainty, what I am calling the New World era. And by that I mean the COVID-19 pandemic era. We have many questions for now and for the future. What does safe childbirth look like in the COVID-19 era? Is it safe to labour and huff and puff with aerosol spread of the virus? Do pregnant women have to wear masks while in labour or when they have their caesarean section surgery? Importantly, are visitors allowed to support and comfort women in labour? How is the baby cared for if their mum is COVID positive? And one of the major roles of healthcare professionals is demystifying vaccination in pregnant women. These and many other questions occur, and we are working through the answers to these questions now. What is known for sure is that this new world era will last some time, and we will need the next generation of obstetric anaesthetists to innovate and collaborate so that the needs of pregnant women and their babies are met. So what does the future look like even further? Well, there is a fairly urgent need for an historical project to create a timeline and document all the key people that were involved in the development of obstetric anaesthesia in Australia, as this talk has only touched on a few people. From the first Department of Obstetric Anaesthesia at the Royal Women's Hospital in Melbourne sprang many departments of obstetric anaesthesia with dedicated directors, as well as other anaesthetists who have leadership roles in the area of obstetric anaesthesia. These people uphold high standards of practice for pregnant women. To all of you, too numerous to mention in this short talk, I extend on behalf of pregnant women my gratitude for your service. I would like to acknowledge my wonderful research team here at the Women's and the supporters of the work we do. And finally, I would like to thank you all for your attention. Hopefully one day in the future, I can update you all on the events of this new world era and do it in person from the luxury and now privilege of a podium. Thank you.